also active in office bearer of the BC, the Breast Imaging Society of India. So I'm very happy. Thank you very much, Rupa, for accepting this invitation to enlighten our surgical oncologist student. And I really thank you with my heart. And over to you, please.
Okay, thank you, Som. Thank you, Mr. Navneet, for having me here. And since we have a lot to cover in the next 40 minutes or so, let's get cracking. Okay. Just a minute. Can I start? Can I start?
Yes, please.
Yeah. Welcome and greetings from Bengaluru. Okay. So the imaging of the breast consists of a lot of various modalities, including nuclear medicine and imaging for staging. But for want of time, today we will concentrate mainly on mammography. We will touch on ultrasound and MRI and talk a bit about interventions. Mammography is the gold standard of breast imaging. It remains so despite so many decades. It is the only validated imaging technique for early diagnosis still. And saving lives really depends upon early detection of breast cancer. There has been a 30 to 40% reduction in mortality rates in countries with regular screening mammograms. We have a number of studies, many of them which have come from Sweden, from Professor Tabar, which has actually showed that regular screening mammograms in asymptomatic women above a certain age definitely saves lives. Mammography can be diagnostic. That's when you do a mammography in a patient who comes to you with a symptom. It may be a lump in the breast, lump in the armpit, unusual discharge for nipple. When you do a mammogram in such a patient, it's a diagnostic mammography. On the other hand, if you do regular mammograms in asymptomatic women above a certain age, looking for very early breast cancers, that is screening mammogram. But it's very important to realize that you or the radiologist will not see a pathology if you don't have a good mammographer. So quality is paramount in imaging of the breast, particularly with mammograms. There are two standard views which we do in mammography, and that's the mediolateral oblique view and the craniocaudal view. We'll talk about those in detail. There are supplementary views like the lateral view or the extended craniocaudal view when you are looking for lesions in the axillary tail region, etc. The mediolateral oblique view is the cornerstone of breast imaging of mammography, and it is taken along the line or along the angle of the pectoralis major. So that is how the breast is imaged during the mediolateral oblique view, and the breast is compressed supro-inferiorly for the craniocaudal view. And this is how we do a spot compression view. When you see some abnormality on the mammogram, on the MLO or the CC view, and you want to make sure it's really there or it's probably just overlapping breast tissue, we do a spot compression view. And there are various paddles which can be done for spot compression views. And this is one of the paddles which can be used. Now, how do you know that you have got a good MLO view? How do you know your radiologist has given you a good MLO view? There are 3 points to discuss for this. Number one is you need to get the nipple in profile. You need to get the pectoralis major there in a gentle V. The entire pectoralis major should be included. The angle between the apex of the pectoralis major and the nipple, this angle here should be 90 degrees, and you should try to get the inferior mammary angle as well as the inferior mammary fold. For that, the mammographer has to lift the breast. So if you have all these 3 points, you know that as much as possible of breast tissue is covered in the MLO view. But if the breast tissue is not covered, you will not see the pathology which may or may not be hiding in that covered part of the breast tissue. What about a CC view? In a good, well-taken CC view, where the mammographer has gone as posteriorly as is required, you will probably see a little bit of the pectoralis major over here. It's in the middle third here. So that means the breast has been pulled forward and as much as required of the breast tissue has been obtained. Even if you do not see the pectoralis major on the CC view, if the distance between the nipple and the posterior aspect of the breast on the CC view is the same as this distance seen on the MLO view or within 1 centimeter, that means you have gone posterior enough. Again, you should try to see the nipple in profile, and on the CC view, try to get the medial aspect, the medial fold on the medial aspect of the breast. That means, again, you have covered as much of the breast as is possible. So again, this is how you read a mammogram. So now we do it on monitors, but before we used to do it on films. Put the CC against the CC and the MLO against the MLO. And by convention, on the CC view, the marker is placed on the lateral aspect of the breast. Okay, so on the CC view, that's the lateral, this is the medial. And on the MLO view, the marker is kept on the superior aspect. So this is the suprolateral aspect of the breast, and this is the infromedial aspect of the breast because it is being imaged along the angle of the pectoralis major. So those are fairly well taken mammograms which you are looking at for any pathology. Now, mammography has gone through a lot of technical advances over the decades. We started with analog, we had computed radiography, we have digital mammography now, and now we have tomosynthesis. Just let's touch upon the physical points of each of this. Okay, so this is how a typical mammography is taken. You have the X-ray tube, the X-ray beam passes through the compressed breast, and the image is acquired on an image receptor. When this image receptor is directly a film, you have the analog images, which we used to work with about in a couple of decades before. And later, in a mammography unit, this image receptor was changed from a film to a cassette, and then you had computed radiography. Everything else was similar to the analog image. And then we went entirely digital, where the entire process became digital mammography. And that's what we call as full field digital mammography. In full field digital mammography, we have two varieties. We have what's called the direct conversion and the indirect conversion. In direct conversion, the X-rays, after having passed through the breast, will go directly on a photoconductor, which is amorphous selenium, and will be converted into an electrical readout, which then goes into the readout process. In an indirect conversion, you have the X-rays, after having passed through the breast, touch on a scintillator, where the X-rays are converted into light, and then they go onto a CCD, and this light is then converted into an electrical process. So that is full field digital mammography. And then we had tomosynthesis. So one problem sometimes we had with mammography is we were looking at a 2D image of a 3D structure. So overlapping structures, particularly in the breast of the same density, could be obscured. So then we came with this idea of taking multiple views from different angles of the breast, so that would easily separate benign lesions from malignant lesions. And that's what tomosynthesis does. Okay, so the X-ray tube moves in an arc across the breast. Multiple low dose images are acquired at different angles, and these projected images are reconstructed at 1 millimeter slices. So now on tomosynthesis, instead of looking at one image, the radiologist actually will look at multiple slices through the breast. So that will prevent any lesions being obscured by overlapping tissue. Now, how do you report a mammogram? So that's most important. Okay, so it's very important, like, to go through a checklist at any point of saying anything you do. Go through a checklist so that you do not miss anything. So this is my checklist for reading a mammogram. I first grade the breast. I particularly look for signs of early breast cancer, which can be a mass, microcalcification, architectural distortion, asymmetry, all of which we will discuss. I look for other lesions. I look at the skin and the nipple. I evaluate the axilla. I look at my review areas, so I'm sure I'm not missing anything. I come to a conclusion. I give a BI-RADS, and then I give a recommendation. So let's look at all of this step by step. Breast grading. This is recommended by the American College of Radiology, and this just tells the radiologist and the referring clinician how much of glandular tissue there is in the breast. Because if you have more of glandular tissue, actually masses also which have a similar attenuation to glandular tissue can be obscured. So depending upon the amount of glandular tissue, the breast is graded from A to D. So an A is a very fatty breast, and as the glandular tissue increases in this proportion, it goes to D. So let's just look at some examples, okay? Sorry, just go back. So that's a very fatty breast. I'll be very confident in reading that breast of this mammogram and saying whether there was a lesion or not. As the glandular tissue increases, as the whiteness increases, the grade goes from A to D. So this is the bilateral mammogram of a very fatty breast, category A. Very easy for me to read, and very confidently I can tell you that there is no lesion there. On the other hand, if you have a breast like this, very white, most of the breast parenchyma is glandular tissue, it's very hard for anybody to say that this is a normal mammogram. So that's how we grade mammograms. Now let's look at the signs of breast cancer. The commonest appearance of breast cancer is a spiculated mass. So you know, ductal carcinomas are serous in nature, so they produce a central soft tissue with radiating spicules, which can be very well seen on a mammogram. It is often associated with architectural distortion and may be associated with skin and nipple changes. So if you see a spiculated mass, which I'll show you examples of, that is a breast cancer unless proved otherwise. The other differential diagnosis for a spiculated mass include a radial scar, or now what we call a complex sclerosing scar, or a surgical scar. But this we cannot tell unless we have a biopsy, and a spiculated mass is a carcinoma unless proved otherwise. Let's look at some spiculated masses. So that's a classical spiculated mass there in a fatty breast. You see a central soft tissue density with radiating spicules. So that's a ductal carcinoma unless proved otherwise. Sometimes the spicules can be much larger. You can see a small soft tissue density here with long radiating spicules, a spiculated mass, cancer unless proved otherwise. Spiculated masses can be created by surgical scars. You can see the soft tissue scar over here and the post-operative surgical scar, but without a history and without previous images, it'll be very difficult for me to say that this is a surgical scar and not a ductal carcinoma. So it's important to remember all masses are not cancer. We can get benign masses in the breast. And here you can see there is a well circumscribed mass. You can see, though it's a very small mass, you can see all the margins are very well circumscribed. So this is very unlikely to be a cancer. It could be a cyst, it could be a fibroadenoma, but we cannot say only with the mammogram, and we would go on to do an ultrasound to see what the internal echo texture or the internal character of this mass is. Sometimes you have large masses. Most of the margins appear very regular, so you would be forgiven for considering this first to be a benign mass, but it's important to look at all the margins. So look at the posterior margin on the MLO and the CC view, very, very irregular. So before calling something well circumscribed, make sure all the margins are well circumscribed. This looked well circumscribed, but when we did an ultrasound, we could see that this was not a simple cyst. This had a solid component. So this was a complex solid cystic mass. This was an intracystic carcinoma. So all the margins have to be very well evaluated before calling something well circumscribed. Some masses are typically benign when you look at them on mammogram. So this was a lady who had a vague lump in the left breast, and you can see on the CC view, it is quite dark, isn't it? So this is lucent, this is radiolucent. So this is fat. It looks exactly like the fat in the retroglandular area. So this is a fat containing lesion. So it will be either a lipoma, or in this case, because it contains some glandular tissue also, it is a fibroadenolipoma, a leave alone lesion, that is a hamartoma of the breast. So most fat containing lesion, or what we call radiolucent lesions in the breast, are benign. Let's look at the next point, microcalcification. Microcalcification refers to small areas of calcification in the breast, ideally less than 0.5 millimeters in diameter. Microcalcification in the breast can be malignant, can be ductal carcinoma in situ or invasive cancer, but it can also be a lot of benign conditions. It could be fibrocystic change, it could be secretory calcification, skin calcification. And the idea is to pick up the benign microcalcification without over-diagnosing the malignant microcalcification. So how do we do that? When we look at microcalcification, we assess the shape, the density, whether the microcalcification is forming a cluster or a group, what is the shape of that cluster, and how microcalcification is distributed in the breast. So we will look at examples of this as we go along. Let's look at some definitely benign microcalcification in the breast, which you can ignore. So sometimes you get these large popcorn-like macrocalcifications in the breast. This is typical involuting fibroadenoma, benign calcification. In older women, you get this tram track-like appearance of linear calcification. That's vascular calcification, again, benign calcification, BI-RADS 2. Sometimes you get multiple foci of microcalcifications. You can see there are small clusters of microcalcifications, but they're on both breasts, and they do form clusters, but these clusters are quite round. They're not irregular or triangular shaped. They do not point to the nipple. So though this is microcalcification, because the calcifications are in clusters which are round and regular, because they are in both breasts, we would consider this as benign, and this is benign secretory calcification of sclerosing adenosis. When you get calcification with a central lucency, that's most often benign. It can be calcification in the skin, or it can be calcification, secretory calcification within the ducts. So look very closely for that central lucency. Sometimes you get, together with vascular calcification, you get these large rod-like calcifications in the entire breast. This is classical plasma cell mastitis seen in older women, secretory calcification, and benign again. Post-operative calcification can be sometimes tricky, particularly in the early stages, but later, in a post-operative patient, post-radiotherapy, we often get this sort of clumped calcification with lucent areas within. So you can see that, fat-like areas within. This is the classical fat necrosis, clumped calcification, again benign, very commonly seen post-radiotherapy, often 12 to 18 months after radiotherapy. What about suspicious calcification? According to the current BI-RADS, suspicious calcification, which requires biopsy, what we call stereotactic biopsy, is classified into 4 types: amorphous, coarse heterogeneous, fine pleomorphic, and fine linear or fine linear branching. Let's look at examples. Okay, so that's coarse heterogeneous. It looks very coarse and it looks very irregular in shape. And then you have amorphous calcification, fine calcification, where you really can't identify the shape. A couple of years ago, these were actually could be followed up, but now even coarse heterogeneous and amorphous calcification, we are suggested to do a stereotactic biopsy to prove benignity. But when you come to the fine pleomorphic calcification, pleomorphic refers to variable size, shape, and density. Okay, so you can see each microcalcification, though very faint, is different from the adjacent calcification. It varies in size, shape, and density. So it is pleomorphic. That's likely to be ductal carcinoma in situ. And when you get fine pleomorphic microcalcification and it begins to have a linear or a branching pattern, you're quite sure you're dealing with malignant microcalcification. It's also considered as crushed needle. Okay, so you have linear microcalcifications with a crushed, broken needle sort of pattern, pleomorphic, varying in size, shape, and density. Or you can have the crushed stone calcification, where you have more rounded calcification in the walls, again varying in size, shape, and density. So that's what you're looking for. And you also have to look not only at the morphology of the microcalcification, you have to look how is it distributed in the breast. Is it diffuse? Is it all over the place? Or is it only one portion? It's probably benign. But if microcalcification begins to have a linear or a segmental distribution in the breast, then you are most likely dealing with malignant microcalcification. Let's look at some examples. Okay, so you can see calcification here, again fine linear. You can see all those calcifications are pleomorphic. They vary in size, shape, and density. And on the MLO view, you can see the classical segmental distribution of that microcalcification pointing towards the nipple. That is malignant microcalcification. Another example, you can see one area of coarse heterogeneous calcification, which is actually an involuting fibroadenoma. But adjacent to that, you can see another area of microcalcification, again fine and pleomorphic with a linear distribution. So linear or segmental distribution suggests that this is malignant microcalcification. Again, another example, very nicely, you can see the triangular nature of this segmental microcalcification, which points towards the nipple. And in the examination, if you really can't assess this microcalcification, you could ask for a magnified view, which will help you assess the microcalcification better. You can see that each of these foci of microcalcification vary in size, shape, and density. So actually in a mammogram like this, you really don't need a mammogram to diagnose that this lady has a malignancy in the superolateral aspect of the left breast and that she also has enlarged lymph nodes. But what you need a mammogram for is to look for the associated extensive ductal carcinoma in situ, which will give you the entire extent of malignancy in this patient. And so that's the rationale of doing mammography in a proven carcinoma. It's to look for multicentricity or multifocality, to check the other breast, make sure the contralateral breast is okay, to look for associated DCIS, which will give you the entire extent of the breast cancer. And also you need a mammogram for baseline for this woman because she would require regular mammograms as follow-up for her for an extended period of time. So this is going to be your baseline mammogram. Architectural distortion is another way malignancy presents. It's rather like a spiculated mass, but what you do not see here is you do not see the central mass. You just see the radiating spicules, again, carcinoma unless proved otherwise. So this is what architectural distortion looks like on the MLO and the CC view. It can be very difficult to pick up. Tomosynthesis really helps us to pick architectural distortion, but you can see there are a lot of lines extending towards a central portion without a definite mass. So there is a break in harmony of the glandular tissue in this area, and this is architectural distortion, malignancy unless proved otherwise. This is again architectural distortion, MLO in CC view in a patient, in a surgical scar. So that's architectural distortion on the MLO view and again on the CC view. So you do not see a central mass, but you just kind of see all those radiating spicules. But again, without a history, we couldn't have said that was a surgical scar. Another example of architectural distortion, very well seen on this CC view. This turned out to be a radial scar or a complex sclerosing lesion. Again, one cannot say without doing a biopsy. So it's a BI-RADS 4 lesion. Asymmetry is again a very subtle way in which cancer presents, particularly lobular cancer, and that's why you need to compare both. That's both views, and that's why you put CC against CC and MLO against MLO. You are looking for areas of whiteness or glandular tissue in areas which should not be there. And that's how often lobular cancer presents. So look at your review areas. Look at the retroglandular area, retroareolar area, the medial breast on the CC and the inferior breast on the oblique views. These are areas where actually you should see fatty tissue. But if you see unusual asymmetric glandular tissue in the medial breast on CC, on the inferior breast on oblique views, you're probably looking at something which needs a biopsy. So asymmetry, according to the current guidelines, is asymmetry, focal asymmetry, global asymmetry, or developing asymmetry. Let's look at examples of that, okay? We looked at this example for calcification. This is bilateral MLO view. The inferior aspect of the MLO view on the right side shows fatty tissue, but on the left side, it shows unusual asymmetry, unusual glandular tissue. So this is focal asymmetry, requires biopsy, and that was a lobular cancer, okay? Focal asymmetry, again, very nicely seen. When you see it on both views, you call it focal asymmetry. When you see it only on one view, you call it asymmetry. So this is again focal asymmetry, superolateral aspect of the right breast with an enlarged lymph node. You may not have picked that up if you hadn't had the other CC view to compare. This is again lobular cancer. Developing asymmetry, often seen in when you image the patient at regular intervals. You can see some soft tissue density here in 2017. It increased in 2018, again, lobular cancer. Always look at associated features like you would do in a clinical examination. Look for enlarged lymph nodes. Look for thickened skin and trabecular thickening, which will give you the entire extent of the cancer. Don't be satisfied with finding one lesion on the MLO view. On the CC view, you can actually see it's on a different quadrant altogether. So these are multiple lesions. Again, changes management. So that's multicentric cancer. And do not, when you see multiple lesions, be sure that you evaluate every lesion separately. This was a lady with multiple cysts. So that's a cyst, but you can see adjacent to that, she has developed a mass, which on the CC view very clearly shows irregular margins. So that's carcinoma in a lady who has multiple cysts too. So each lesion should be evaluated separately. Do not forget the axilla. Very common in our population to see benign lymph nodes. They have a nice oval shape there, very well seen on the MLO with lucent center. That's the fatty hilum. But once you see large bulky lymph nodes like that, which lose their oval shape and do not show central lucency, you are dealing with pathological lymph nodes. And sometimes you can even see the microcalcification within the lymph nodes. Coming to BI-RADS, that refers to the breast imaging reporting and data system. This is a way of the radiologist communicating to the referring clinician, that's to you, what we feel on a mammogram. So the classical BI-RADS had only five categories, 1 to 5. Suppose a mammogram was normal, it's BI-RADS 1. If it had benign features, you might find vascular calcification, involuting fibroadenomas, it's BI-RADS 2. Patient goes back to normal screening. BI-RADS 3 refers to you finding a lesion which is probably benign. You might find some small punctate calcification or a well circumscribed mass. Your level of suspicion is less than 2%. You could ask the patient to come back for follow-up in 6 months. But if your suspicion for malignancy is more than 2%, it goes to BI-RADS 4. You will need a biopsy. If your level of suspicion is very high, you're finding a classical spiculated mass, or you're finding a fine pleomorphic branching type of microcalcification, you know this is cancer, then it's BI-RADS 5, and the patient can go on straight for biopsy and treatment. So that's BI-RADS 1 to 5. We have now BI-RADS 6, where we evaluate a known cancer. So probably the biopsy has already been done. You know the patient has cancer. You want to see the extent. That's BI-RADS 6. Or it's a follow-up after neoadjuvant chemotherapy. That's BI-RADS 6. And then we have BI-RADS 0, which can be a little tricky. That means that the radiologist needs a further evaluation. She or he needs to do an ultrasound, or we would like to compare previous images. So our assessment is not over. We are calling the patient back for further evaluation. And after that, we will assign a BI-RADS, which can be anywhere between BI-RADS 1 to 5. Since 2003, BI-RADS 4 has been divided into A, B, C, because so if your level of suspicion is less than 10%, you think it's a benign lesion, but you still want a biopsy to confirm it, we put it in BI-RADS A. Anything above that, 10 to 50% is our level of suspicion, is BI-RADS B. And more than 50%, you're most likely, you really think this is a cancer, but you need biopsy for further evaluation. That goes on to BI-RADS 4C. And it's important for us to tell the clinician what we need next. So we put in a BI-RADS and say that I think this is BI-RADS 0, but I need further images. Please send the patient back with all previous images for me to complete my evaluation. So it's not sufficient that we say BI-RADS. It's important that you actually give the recommendation. So take home points for mammography. Remember, mammography is still the gold standard. Good quality is essential. Make sure in your practice and in your exam, you're looking at a good quality mammogram. The primary aim of mammography is the diagnosis of breast cancer. So look for the subtle signs of breast cancer. Look for speculation. Look for microcalcification. Look for architectural distortion. And look for asymmetry, particularly in your review areas. Let's just go on next to ultrasound of the breast. Breast ultrasound has some specific indications, and it works very well when you use it for those specific indications, not when you do it for indications which is not meant for. So breast ultrasound is the first evaluation we use when we are evaluating a breast lump in a woman less than 35 years. It's what we use in pregnancy and lactation. We will use an ultrasound sometimes when we see a mammographic abnormality. We are really not sure what it is. We want to evaluate it further. We will do an ultrasound. Or clinically, there is a mass palpable. It's probably part of a triple assessment, but the mammography is negative. Always remember, in up to 80% so up to 20% of breast lumps, a mammography can be negative, even in the best of hands. We use breast ultrasound for interventional guidance, for evaluation of mastitis, the male breast, breast implants, and as a very useful tool for evaluation of nipple discharge. So let's look at some examples. But it's very important to realize that ultrasound does not replace mammography. It's not a screening tool. It's used together with mammography as a screening tool in dense breasts, younger women, or high-risk women. It is not validated as a screening tool yet. It's important that we use a high-frequency probe, what we call a linear probe. And so generally, more than 5 megahertz is what is required for a good evaluation of the breast. As breast ultrasound is done with the woman in the supine position with the arm raised, so the pectoralis is nicely relaxed and we can evaluate the breast well. So you may get an ultrasound report. You need to know what we mean when we document lesions. So we label the side, we write a lesion either in the o'clock position or the quadrant position or both. We mention a lesion as a distance from the nipple, and we also indicate the depth from the skin. Ideally, measurements should be given in at least 2 perpendicular measurements. So this is how we document a lesion, okay, in the o'clock position. So the medial aspect of the right breast is 3 o'clock and the lateral is the 9 o'clock, while it is reversed on the left breast. The lateral is the 3 o'clock and the medial is the 9 o'clock. There are some schools of thought who, create these circles. So you have 1, 2, 3, depending upon the distance from the nipple, and you have A, B, C, depending upon the distance from the skin. But it's much more easier and well understood if you write, or radiologist gives you that there is a mass in the superolateral aspect of the left breast at 1 o'clock, dimensions 3 by 2 centimeters, situated at a distance of 2 centimeters from the nipple or the areola and a depth of 1.5 centimeters. So that's much better, easily understood. So when we evaluate a mass on ultrasound, we look at the shape and the margin and the capsule and lots of other features which we will look at in pictures. There are some typical benign lesions which we can see on ultrasound. Those can be cystic, that means full of fluid, or they can be solid and they can have typically benign characteristics, so we can categorize them as benign. Classically, a cyst is black on ultrasound. It's black on ultrasound because it allows all the ultrasound waves to pass through without stopping anything. So we find a nice, well circumscribed black lesion like this. We know that that's a simple cyst. Cysts can have thin septae. They can have some low level echoes. That's just a complicated cyst. Again, nothing to worry. But a cyst cannot have a solid component like that, particularly if there is increased vascularity. So if you see solid or gray areas within a cyst, it's no longer a cyst. It is a complex cystic and solid mass according to the current BI-RADS. That is either an intracystic carcinoma or an intracystic papilloma, and biopsy is required from the solid component of that. Ultrasound is a great tool to evaluate the lactating breast. Okay, so we see parenchymal edema, and then it increases, and ultimately we can see a well circumscribed liquidy area like that, and that's an abscess. Again, we can easily distinguish an abscess which has a thick wall from a galactocele which has sort of a spidery appearance of these dilated ducts. So that's a galactocele. Granulomatous mastitis, sometimes very difficult to diagnose, but sometimes we get these very characteristic tubular fluid-filled areas leading to a sinus, as very characteristic of granulomatous mastitis. But of course, we do need biopsy to confirm the diagnosis and for treatment. What about solid lesions? How do we tell a solid lesion is benign or malignant? Okay, so the classic solid lesion we see is the fibroadenoma. Okay, a fibroadenoma is a benign lesion, so it has an oval shape. It is wider than it is taller. Okay, it has a well-defined capsule because it is benign, and it has a characteristic which is known as posterior acoustic enhancement, which I'll show you examples of. Okay, fibroadenomas, however, can have varied appearances and sometimes needs biopsy to prove it is benign. Again, a nice oval shape, well-defined capsule. Sometimes it can show cystic areas. It can show gentle lobulations in the margin, but more or less benign. A phylloids actually looks sometimes looks very much like a fibroadenoma, but often it has these small fluid-filled areas within, which are called fluid clefts. And often it shows a rapid growth. And that's how we sometimes ask you to biopsy a fibroadenoma, though we think it is, because we're not sure we are ruling out a phylloids. Lipomas, we can always give you a diagnosis. They are much better felt than seen. They can be in the superficial area over here looking very white or hyperechoic, or they can be deeper and hypoechoic with thin septa. Lipoma has a classical appearance on ultrasound. What about a carcinoma? Carcinoma looks very different from a fibroadenoma. It is very dark, so it's not as gray and homogeneous as a fibroadenoma. It looks very hypoechoic. It is taller than wider. That's because it is breaking the facial planes. The margins look very angular. They're not well circumscribed, and there's no definite capsule. And you have a characteristic which is known as posterior acoustic shadowing. You can see a dark black shadow behind the cancer, and that's because it is not allowing any of the ultrasound waves to pass through. So again, going through benign and malignant, a benign mass on ultrasound is an oval shape, a smooth margin, and it is sort of uniform, and it may show an acoustic enhancement. It will show a white area below the mass. But a malignant mass, on the other hand, will have an angular margins, variable shape, and it will show acoustic shadowing. So that's what a benign mass will look like, well circumscribed, oval in shape, with a white area behind acoustic enhancement, while a malignant mass will look very black. It will be taller than wider, and it will show an acoustic shadow. So that's a malignant versus benign mass, but there's a lot of overlap. Breast cancer, as you know, can be very heterogeneous, particularly triple negative cancer. So always a mass is diagnosed by its most malignant character. So though this mass is very well circumscribed, it's got a homogeneous appearance, it has an oval shape. If you look at the margins, you can see they have a little angular, or what we call a microlobulated margin. So we characterize this as a BI-RADS 4 lesion. We biopsied it, and that turned out to be triple negative cancer, which can remarkably look like a fibroadenoma on ultrasound. Ultrasound also very nicely helps you to show identify a contralateral lesion. So it's not sufficient that we diagnose one lesion. We always check the other breast and the axilla, looking for more lesions. Again, the axilla very well evaluated with ultrasound. A benign axillary lymph node has an oval shape. It has a central echogenic area, which refers to the fatty hilum, and it has a very regular sort of vascularity. But when this is replaced by a more rounded shape compared to an oval shape, and the central echogenic fatty hilum is replaced by hypoechoic tissue, we are looking at pathological lymph nodes. Ultrasound has a very important a part to play in nipple discharge. Of course, the worrisome discharge is the unilateral bloody spontaneous discharge, or a clear discharge spontaneous, which is associated with mass. So what we're looking for is carcinoma or duct papilloma. So the ducts can be identified on ultrasound as these white lines, but when they are filled with fluid, they become like these black tubular areas. So these are the dilated ducts in the retroareolar region of duct ectasia. And if we're lucky, in a patient with a nipple discharge, we can find a single dilated duct, and we can identify that intraductal papilloma for you with increased vascularity. Male breast, again, the first technique we use is an ultrasound. So sometimes in gynecomastia, we can nicely see this retroareolar bud, which looks more prominent. So we know it's gynecomastia. But if we see a mass which is subeccentric, it's just away from the retroareolar bud, slightly eccentric, and it has an irregular margin, and it has increased vascularity, we are actually looking at a carcinoma in the male breast. Ultrasound is a beautiful technique for doing biopsies. Okay, we can, so that's the core biopsy needle which we use. So you can actually identify on ultrasound the biopsy needle going through the mass. Okay, so if we do not see something on an ultrasound, we would have to do a stereotactic biopsy. A stereotactic biopsy is done on a mammographic unit. It is generally done in the sitting position. We identify the area which has to be biopsied by taking two views, 15 degrees plus and negative, and by feeding this in the machine, the stereotactic equipment will give you the exact site of having to go in for a biopsy. So that's how we do stereotactic biopsies. We reserve stereotactic biopsies for lesions which cannot be seen on ultrasound. Okay, and for stereotactic biopsies, especially when we are doing calcifications, we use a vacuum assisted biopsy. It's much larger than a core biopsy. It's about 7 gauge. So we get large chunks of tissue with microcalcification. And post biopsy and post lumpectomy, we always do a specimen mammography, making sure that we have got the lesion we wanted to target. Elastography, you might be asked this in the examination. This is a new technique which just helps us to assess the compressibility or the hardness of a tissue. That can be strain elastography or shear elastography. So something which appears very hard, and it actually on the graph it will be red on ultrasound, on elastography of ultrasound, suggests that that's a malignant lesion. And now you have what we call automated breast ultrasound, where you get actually multiple slices of ultrasound through the breast, which helps us identify those small lesions, which again may be obscured by overlapping breast tissue. So take home points for ultrasound. Breast ultrasound is very useful in characterizing masses. It does not replace mammography as screening. The niche applications are mastitis, nipple discharge, interventions, pregnancy, lactation, evaluation of a lump in a woman less than 35 years, implant evaluation, and the first evaluation in a male breast. Let's spend about 10 minutes on MRI, the new kid on the block. MRI, remember, is a problem solver. It's not usually the first investigation we do. According to the ACR, MRI is used to evaluate a suspicious mammographic finding, to evaluate the disease extent in malignancy, to monitor response in neoadjuvant chemotherapy, differentiating scar from recurrence, and searching for the breast primary when you have positive axillary lymph nodes, but you can't feel a mass in the breast, or you can't identify it on mammography or ultrasound, and for screening in high-risk women. So it's used only for screening in high-risk women. These are women who are either BRCA1 or BRCA2 positive, or first-degree relatives with BRCA1 or 2, or those with radiation treatment during childhood or early adulthood for lymphoma. So annual screening with mammogram and MRI is suggested according to the ACR if the lifetime risk of malignancy is 20 to 25% or greater. Otherwise, you continue screening with mammograms. So what do you need for a good MRI? You need a high field technique. That means you need a magnetic strength of more than 1.5 Tesla. T stands for Tesla. You need a dedicated breast coil. I'll show you one. The MRI has to be capable of taking multiple images in a fast sequence to see how contrast accumulates in the breast and in masses. So that's what we call multi-phase contrast imaging should be capable in your MRI machine, and it has to be able to do fat saturate. It has to be able to saturate the fat, remove the fat, so you can see enhancement better. There are a number of protocols, but this is what is generally done. You have T1, T2. We'll talk about that later. But the most important sequence in an MRI breast is what we call post-contrast facing sequences, where you take multiple slices in a fast manner through both breasts immediately after contrast is done. So that is done in about about 4 minutes. It's called Vibrant in G, it's called Views in Siemens. So different names according to the vendor, but the main point is, after giving gadolinium, which is the contrast we used in MRI, multiple images are taken through both breasts in a fast sequences, which has to be completed within 4 minutes. So this is the breast coil. In an MRI breast, the woman is in the prone position. So this is the breast coil, and these are the breast cups into which the breasts rest. Okay, this is where the chin of the patient rests, and this is the SIFI sternum. Okay, so these are the sequences, what they look like. That's T1, T2, post contrast imaging. You can see that white area is removed, and that's because the fat is saturated, which helps you see the lesion better. Okay, so because it's in the prone position, this is the right breast and that's the left breast. Okay, and that's a post contrast imaging in the sagittal view. So again, on MRI, we evaluate masses. Again, we look for an enhancing mass, and if we see an enhancing mass, like on mammography or on ultrasound, we look at its margin, we look whether it is well circumscribed, but we also look how it enhances with contrast. So something with on MRI with a smooth margin, gentle lobulation, no enhancement is likely to be benign, but something which has a spiculated margin, an irregular margin, or has a heterogeneous enhancement or a rim type enhancement is likely to be malignant. So again, here is a post-contrast fat saturated image. I've just taken one slice. You can see an enhancing lesion here with irregular spiculated margins, malignancy unless proved otherwise. In another case, you can see a more well circumscribed oval shaped lesion. It shows some enhancements, but it's very clear, very homogeneous. This is a fibroadenoma. We look at another part in MRI breast, which is known as non-mass enhancement. That is enhancement in the breast without an actual space occupying lesion. Okay, so we look at examples of that again, but let me just talk about how we assess non-mass enhancement. So if you find enhancement in the breast, which is on both breasts, it's all over the breast, it's very small foci, it's symmetrical, it's probably benign enhancement. But if you start to see enhancement in the breast, even without a mass, which is segmental in nature, which is ductal or linear in nature, or which has an asymmetrical character, you're probably looking at malignant enhancement. Very often non-mass enhancement is ductal carcinoma in situ. So if you see multiple foci of enhancement in both breasts, very symmetrical like that, that's benign enhancement. But if you see a sort of clustered ring or a sort of heterogeneous enhancement in a segmental manner like that, you are looking at malignant enhancement, most often ductal carcinoma in situ. So even if there is a malignant mass, you must always look for the associated non-mass enhancement, which indicates that the cancer is not only here, there is a ductal carcinoma in situ extending right up to the nipple. Okay, so that's again the right breast, very characteristic irregular mass with typical rim type enhancement. You can see the central part doesn't enhance. That's very characteristic of a malignant mass on MRI. So the question arises, does every newly diagnosed breast cancer need MRI prior to breast conservation surgery? Breast MRI is a very sensitive tool. It picks up multicentricity and multifocality in 15 to 30%. Now, we do MR breast only if there is a high chance of multicentricity, like a lobular cancer. You're not sure of the entire extent of the breast cancer. You would require an MRI to show you the entire extent. It is used only in special indications. Okay, it's very good to show multifocal disease. Okay, you can see there are multiple nodule and enhancing nodules in this sagittal view, indicating that this is multifocal disease. Okay, you would like to do MRI probably in this 20-year-old woman, because she will have a very dense breast. You will not be able to evaluate it well on an mammogram, and to satisfy yourself that there is only one lesion, you'll probably ask for an MRI. Let's just look at one example of how MRI helps in problem solving. This is a 45-year-old lady who felt a very small mass in the left breast, and that's the spiculated lesion there. But there is something like a focal asymmetry on the right breast too. Nothing was seen on ultrasound. An MRI was done. So this is the left breast. It shows the characteristic spiculated mass, but you can see on the right breast, because the patient is prone, there is another enhancing lesion. So this is contralateral cancer. MRI help in problem solving, and she had a ductal carcinoma on the left breast, which she could feel, and a lobular cancer on the right breast, which she could not feel, but was diagnosed with MRI. Just take a few seconds to talk about time intensity curves. You might be asked this in the exam. So this was introduced by Elizabeth Cool and colleagues, and this just indicates how contrast accumulates and behaves in a mass over the 4 minutes which we image the breast. Okay, so we can put a time intensity curve and create a curve over the mass to see how contrast behaves. So over the 4 minutes, if there is a gentle rise in the contrast accumulation, that's probably benign. But if you have a rapid rise of contrast in the first minute and a rapid fall, you're probably dealing with a type 3 curve. That's a malignant curve. Okay, so that's what, if I create a time intensity curve, that's what a benign curve looks like. That's what a malignant curve looks like, you know, rapid upstroke and a rapid fall. And that's because of the neoangiogenesis. Contrast accumulates fast into a tumor and then immediately escapes. And in between, you have an intermediate curve where you have a rapid upstroke and a gentle plateau. So that's type 1, this type 2. And when you have a rapid upstroke and a rapid downstroke, that's type 3, often a malignant curve. But remember, morphology over curvology. Even in MRI, you look at the morphology rather than the curves, and always assess your MRI together with the mammography, because MRI is actually a problem solver. It really works best when you have a mammogram too. I wonder whether, Mr. Navni, do we have 5 minutes to go through some cases, or shall we start the question?
No problem. We can complete 5 minutes.
Yeah,
No problem.
so just go through quick cases. We don't have a voting poll. I'll just go through about 5 or 6 cases, look at it for 5 minutes, and then we'll discuss the answer. So case 1. Okay. Case 2, just the left breast for you. Case 3, CC and MLO views. Case 4, post-contrast MRI, and we flip the image here. So this is the right breast and that's the left breast, a single sequence, post-contrast, fat-saturated, MRI breast, a single view. Case 5, mammogram, CC, MLO, and an ultrasound. Case 6, only MLO view. Case 7, post-operative status, left breast, CC, and MLO. Just come in for a follow-up. And an ultrasound. Which would you biopsy? Which would you ask for a biopsy? The right-hand image or the left-hand image? So want of time, we'll just go through the answers. That case 1, classical spiculated mass. So you can, and that's in the superolateral aspect of the right breast, BI-RADS 5 direct. Okay, according to BI-RADS, you can say this is BI-RADS 5. It's not 4. You don't need a biopsy to say that this is cancer. Okay, the next case. Okay, again, clustered pleomorphic microcalcification, very fine, varying in size, shape, and density, classical segmental distribution with an associated focal asymmetry. You can see the density there with an enlarged lymph node. So this is not only DCIS, it's an invasive cancer because you have a lymph node too. A dense breast, but you can see an irregular mass. I won't call it a spiculated mass, but it's an irregular mass there in the superior and more central quadrant. So this will probably be at 12 o'clock position in the left breast. And adjacent to that, even in this dense breast, you can see some small nodules. So there's multifocality in this cancer. So post-contrast imaging, irregular mass, definitely an invasive cancer with rim type of enhancement, but look at the linear non-mass enhancement. So that's an invasive cancer with more DCIS in the medial and the central quadrant. So she may not be a candidate for breast conservation surgery. Okay, so that's a male mammogram. You can see there's an irregular nodule there, sub-eccentric. Okay, it's not behind the nipple, but it's just eccentric to the nipple. And on ultrasound, you can see it's an irregular mass with increased vascularity. So that's a breast cancer in a male breast. Okay, and so the DD for that would be a gynecomastia. Well, you can see these sort of flame-shaped densities in the retroareolar area, while a cancer would be more of a nodule, and it will not be in the retroareolar region. It will be just eccentric to the nipple. We looked at this, but I just thought I'll show it to you again. The calcific is a very busy mammogram. The calcification is all benign. It's microcalcifications. They are clustered. They're all over the breast, but do not miss this focal asymmetry in the inferior aspect of the left breast, where there is only fatty density on the right side. So that was lobular cancer. Post-operative, so there's a post-operative changes, a sort of a veil-like density there. That's a classical seroma at the site of surgery. But what we should assess and not miss is the microcalcification in the right breast. Okay, so there, so classical pleomorphic calcification in the contralateral breast. That's BI-RADS 4C, I would call it. And this we probably will not be able to see on ultrasound. We would need a stereotactic biopsy to biopsy that microcalcification. And which would you biopsy? Sometimes, as I said, you can get a cyst with some low-level echoes, and that's apocrine metaplasia on ultrasound within the breast, within the cyst. That's probably benign. But when you get this lumpy areas, this increased vascular, particularly with increased vascularity, and that inner cystic area, which then extends into the ducts. You are not looking at a simple cyst. You are evaluating complex solid cystic lesion. This is an intracystic carcinoma, and we need to biopsy the solid component of that cyst. So in conclusion, mammography is still the gold standard. Insist on high quality images in your practice. Ultrasound is a good tool, but not yet a screening tool, but it gives very good results when it is used for the niche applications which we've discussed. MRI has very high sensitivity, a very high negative predictive value. So if you look at benign, a normal MRI, you know that this lady does not have a cancer, but because it picks up a lot of enhancement, it lowers the specificity, but lots of leaps and bounds, a lot of imaging is and advances are going in for MRI of the breast. But it's very important to encourage your patients when you go into practice after your exam to examine their breasts regularly, to come in for regular tests, because remember, breasts are like husbands, they need to be checked regularly. Thank you, ladies and gentlemen. I'm open for questions. Navneet?
Thank you very much, Dr. Rupa. There are a few questions in the chat box.
I'll just go, so just down, right?
Rupa, both in the chat box and Q&A, there are questions.
I'll just go to, so I'll have to go down, right? Yeah, I'm just trying to get.
Yeah, next to that video icon, if you want, I can also read it.
Yeah. You can yes, you can, yeah, fine. What is the role of mammogram in carcinoma? So I think we've looked at that, okay? You really don't always need a mammogram in the male breast, because you most often would be doing a complete removal of the breast. But it's most often we do a mammogram not to diagnose the carcinoma in the male breast, but to distinguish it from gynecomastia, because sometimes it's difficult on ultrasound, but on mammogram you get that classical flame-shaped appearance in the retroareolar area, and that helps us to distinguish a gynecomastia from a male breast. Very good question. Why are malignant masses taller than wider? They are taller than wider because they do not respect boundaries. They break the facial planes and grow supro-inferior, unlike a fibroadenoma, which spreads in the transverse direction. It spreads along the facial planes. Okay. Then what's the next question? What is the basis of subclassification of the BI-RADS 4 category? Very good, because BI-RADS 4 was a big waste paper basket. It was any suspicion from 2 to 95% was in BI-RADS 4. And then we realized we had to recategorize it. So if your suspicion is less than 10%, that you think this is most likely a benign lesion, it becomes BI-RADS 4A. So if you have a BI-RADS 4A, you biopsy it and it turns out to be benign, you are satisfied. You can stop there. But if you have a BI-RADS 4C lesion, you think this is definitely cancer, your level of suspicion is more than 50%, and your biopsy comes as benign, you do not stop. You have to go to the next level. So just to help us to reevaluate the level of suspicion, we have, since 2003, A, B, and C. So less than 10%, most likely benign, is BI-RADS 4A. 2 to 10%, either way, is 10 to 50%, either way, is BI-RADS 4B. Anything above 50%, which is most likely to be a malignancy, is BI-RADS 4C. Can we differentiate TNBC and other types on mammogram? A very good question. There's a lot of literature going on that. And actually one of my my residents has actually done a thesis on that. We're hoping to publish it. Okay. TNBCs look exactly like benign lesions on mammograms, especially on ultrasound. They look exactly like fibroadenomas. That's because they are so rapidly growing. They do not have time to obey the laws of cancer. Okay, so they look oval. On mammogram, they look very well circumscribed. So TNBC looks exactly like a benign lesion on mammograms and on ultrasound. Classical speculated lesions are actually ER/PR positive. Okay, when you get lots of microcalcifications on a mammogram, you're often looking at a HER2 enriched cancer. So there's a lot of literature going on to evaluating the immunohistochemistry from imaging. Fine. But really, we cannot distinguish 100%. We need biopsy still to evaluate the various subtypes of cancer. How to localize the quadrant on mammography? It's because we are evaluating it on ML. The MLO is not a direct perpendicular to the CC. There will be some overlap in the quadrants, but as I said, on CC, it's a very perpendicular view of the breast. So the medial aspect is medial, and where the marker is lateral. Okay. On an MLO, what is towards the upper and the outer quadrant would be the supralateral quadrant. What is to the inner and the upper quadrant would be the upper inner quadrant, and so on. And of course, what is adjacent to the nipple would be the central quadrant. But because on MLO, there's a little bit of overlap, sometimes medial lesions, they're actually in the medial aspect of the breast. But when you do a mammogram, they will be projected on the lateral aspect because of the way we take the MLO view. Yes, so anything else?
And Rupa, now there is a Q&A box.
Yes, I look at that. Yeah.
Yeah, so if you can see that.
So mammographic finding, is it lobular breast cancer, LBC? Yeah. So lobular breast cancer is really a tricky thing to identify on imaging. It's tricky on clinical examination also because it's difficult to palpate because it grows along the lobules. Classically, lobular cancer usually presents as a focal asymmetry. Okay, so you see, that's why we always need both breasts, because you see an added area of glandular tissue with not the typical well-defined margins, especially if it increases in the next imaging, you're probably looking at lobular cancer. So focal asymmetry or a developing asymmetry is what lobular cancer looks like on mammogram. Very difficult to identify on ultrasound. You can palpate it well, but you don't see a well-defined mass. You see some small hypoechoic nodules all clustered together. That's what lobular cancer looks like on ultrasound. On MRI, still not so well visualized as classical ductal carcinoma, usually presents as a non-mass enhancement. So you don't see a classical mass on MRI. In lobular cancer, you actually see an area of non-mass enhancement. So we talked about segmental and linear non-mass enhancement. That's what lobular cancer looks like on MRI. Any other questions here?
Imaging mode in male breast.
Yes, so what I would say is, in a male breast, we would start definitely with an ultrasound, okay? And if the mass looks suspicious, we would go straight and biopsy it. We would also evaluate the other breast and look at the axilla. A mammogram is always not needed to diagnose a cancer in a male breast. We usually do the mammogram if we are not sure whether it is gynecomastia or not, because gynecomastia and a male breast cancer can look similar on ultrasound, but they have very different appearances on mammogram, and that's why we do a mammogram often.
Okay, next, I think Ronak Jain want to become sono surgical oncologist. Some 20 questions he has asked, but good. Is there any difference between the compression we give to the breast in screening mammogram versus diagnostic mammogram?
No, not really. It's diagnostic and screening mammograms are done for both. The imaging technique for both is the same. Okay.
New mammography machine require less compression and less discomfort already nowadays.
No, not really. The compression is the same. It's just a bit quicker. Unfortunately, compression is something which we have not been able to remove from mammography, because that's the only way we can separate the breast tissue. Compression helps us to separate the breast tissue, and it helps to avoid motion artifacts and pick up those small cancers. But what we have is actually we have most of the machines now have an inbuilt feature that as soon as the image is acquired, the compression is released. So the mammographer does not have to release the compression. As soon as the image is taken, the compression releases by itself. So it's very momentary. Okay. We encourage all women, particularly coming for screening, to come in, in the first few days after their period. It's much more comfortable at that time. It's towards the secretory phase that the compression becomes more painful. Tomosynthesis, where is it required? I suggest, I was not a great advocate of tomosynthesis till I started using it. Okay. If you can get a tomosynthesis unit, please do. It's made us pick up so many more cancers, particularly in our screening population. We in Manipal have actually got a good screening population because we have a health check unit and we do about 20 screening mammograms in addition to all our diagnostic mammograms every day. And tomosynthesis helps you pick up those very small cancers, particularly in dense breasts. So I wouldn't say tomosynthesis, where is it required? I think it's required if possible in all cases because it helps you pick up those small cancers. The big cancers you'll pick up even with an analog. What we're looking for are those small cancers, and tomosynthesis helps you pick it up because it separates the normal tissue from the malignancy. It's something like evaluating a chest X-ray and a CT chest. You get multiple slices, so you can always see those small cancers.
Rupa, next question is, the radiation dose, is it same for diagnostic screening memo?
Yes, it is same for diagnostic and screening mammography. Okay, we use the same technique, so that it's the same radiation dose. It's less than a dental X-ray. Okay, four views is less than a dental X-ray. It's probably the same amount of dose you will get if you go 4 times a year to US and back. It's the same radiation. Okay, it's probably less radiation than a lot of people who live probably in Kerala, where there's a lot of inbuilt radiation within the earth. Okay, so I know there is radiation, but the benefits you get of this radiation and picking up an early breast cancer is far higher than the the theoretical risk of somebody developing a breast cancer from the radiation induced. Okay, and actually there's never been, as of now, there's actually never been a proved cancer in the breast because of radiation. Of mammography, there has been proved breast cancer because of a large amount of radiation of women who have had radiation to the chest wall in the developing breast for Hodgkin's lymphoma, but not due to mammography.
Then next question is, what is the size of microcal? She already answered it, less than 5 millimeter.
Yeah,
right?
0.5 millimeter,
0.5
less than 0.5 millimeter.
And then
a cluster is when you have, you call a cluster in a 1 centimeter area. If you have more than 5 microcalcification, you call it a cluster.
good. Next question from Ronak Jain is, do we use magnifying lens to see microcal? You know that the software now has a magnifying software.
Exactly. Yes. So we have,
go down to radiology department and see how they report it. Old time you build the glass, now the software you can use a cursor where it enlarges.
Correct. Absolutely.
There are other more questions, but this is the best we can do. This actually shows so much interesting topic. And Rupa, excellent and very beautifully covered. I always have heard your talks and they're very practical, superb and excellent. Thank you very much. And I will probably borrow your presentation in PDF format and put for the benefit of students.
Absolutely. You're welcome to.
Thank you very much for sparing your time in a busy time, and over to Navneet Singh ji. Thank you.
Thank you very much, Dr. Rupanand, for the presentation. Thank you very much, Professor Dr. Soma Shekhar, for joining us. And thank you, trainees and faculty members, for joining us.
Thank you, and have a good weekend, all of you. Bye.